Hi, I'm Dr. Matthew Norton, the founder of People Plus Purpose, and this is the Truth Behind Dentistry podcast. And today, my guest is Dr. Ed Zuckerberg. Dr. Zuckerberg owned practices in New York from 1979 to 2013 and has always been an early adopter of technology, catching the attention of industry leaders who enlisted him to lecture, write articles, and beta test new technologies. He lectures nationally and internationally on the oral systemic connection, serves as a venture partner at Revere Partners, the first independent venture fund for oral health, acts as the chief dental officer for VIOME and the chief education officer for Cloud Dentistry, in addition to treating patients part-time in Cupertino, California. Welcome to the podcast, Doctor.
Thanks, Matthew. Great to be here today.
Yeah, absolutely. Been looking forward to our conversation. That's a mouthful of stuff that you're just like currently doing. So, and we could probably talk for quite a while about all the stuff you have done that you're not still doing. So that's a lot of things. But I I think I love to kind of look at the arc of people's career and see the path that they've come. And I'm interested after all those years as the owner of dental practices, delivering chairside dentistry, kind of how you have evolved from that to being a leading advocate promoting the role of dentists as primary healthcare specialists.
Yeah, well, I think I never really thought of myself as someone who was an early adopter of technology. I think one of my staff members coined the phrase Inspector Gadget, and patients would often come in and ask me what's new, and it was like whenever they came in, they expected to see the latest, dental gizmo or technology. And it occurred to me that at some point that patients actually associated dentists' adoption of new technology with the dentist being a superior dentist. Now, I'm not making claims.
Right, right.
In fact, in the profession, we know that, just because you buy a fancy tool or gadget doesn't mean that you're better than the next guy or gal dentist out there. But that's the perception it creates in the patient's mind.
Right.
And it's one that we kind of ran with. I had a unique practice. It was a home-based practice.
Hmm.
So from 1981 until 2013, when I retired for 32 years, practiced in an office in our home in Dobbs Ferry,
Hmm.
New York, just north of New York City.
Hmm.
My wife trained as a psychiatrist and actually left her career to run everything non-clinical in the dental office. Of course, we had the lure of her being home,
Mhm.
to be around for our four children.
Right, right.
And, I impressed upon her that between my patients and my staff, her psychiatric tools would not go underutilized. And
Right.
in
Sure.
fact, they did not.
Right,
So,
right.
between that and raising the children and, being a partner to me, she had her hands full.
Yeah.
And so we kind of had we became known as the practice for cowards, for dental cowards.
Huh.
We had a large fish tank that we put in the wall between two of my operatories, like almost 300 gallon saltwater tank to allay patient anxieties.
Right, right.
And my wife and I frequently discussed patient perceptions of the office, and she was kind of a fraidy cat herself. So she utilized her patient experience to, make changes in the office. Things like, hey, I spend a lot of time when I'm in your chair looking at the ceiling. Can you do something?
Yeah.
And up on the ceiling, we had two Lexan panels, housing the fluorescent fixtures. And at the Greater New York Dental Meeting that year, we actually ran into a company that put artistic Lexan panels up on the ceiling, and one of them was an underwater sea fish gate,
Huh.
which fit right in with our theme in
Right.
the
Yeah.
office.
Yeah.
And I had patients brought me giant seashells when they came back from beach vacations, and we had a local artist who needed comprehensive care, who couldn't afford the care, who painted undersea murals on the walls in our office as a barter. Um, we even had um, fish themed toilet and toilet bowl
Wow.
tooth fish themes in the bathroom. um, and a funny story, one day one of the fish in the fish tank had died, and my assistant who scooped it out, instead of disposing it where it might smell in the trash, she decided to flush it down the toilet. But it didn't go down, unbeknownst to any of us. And when one of the patients went to utilize the facilities and saw this, dead fish floating in the toilet bowl,
Right.
I mean, they came out and said, "Hey, I know this guy is into fish, but that's
That's,
ridiculous."
yeah. It's gone too far. Yes.
Anyhow, some of the technologies I employed, first dentist to um, had an IBM PC XT in my office in 1986, and went to online scheduling or computerized scheduling in the late 80s. A lot of resistance from the
Right.
staff,
Yeah. Yeah.
but within 6 months of adopting that system, everybody was like, "This is the greatest thing." Um, we uh, we put in intraoral camera, the AccuCam, the first intraoral camera, back in the late 80s to show our patients what's going on in their mouth with their teeth, help them understand their problems, and also gain better treatment compliance and case acceptance. And ironically, now, almost 40 years later, the guy who developed that intraoral camera system is pitching an ultrasonic periodontal probe system to me now in my role as a venture partner at Revere Partners.
Interesting.
So, along the way, there were lasers and air abrasion, first dentist to utilize digital X-ray in my area in 1998, way before the curve.
Right. Yeah.
Um, Wanted to adopt a digital electronic health record system in 2005, but there were none commercially available for dentists. So, along with my then son-in-law, we built one ourselves. Um, CAD/CAM technology to do same-day crowns and veneers in 2008. And then around May of 2011, actually 13 and a half years ago or so, our first grandchild was born in California. Now, at that time, we already had three of our four children living in California. My son started the migration in 2004 when he founded Facebook.
Mm-hmm.
A year and a half later, he got my oldest daughter, who had graduated from Harvard and was a marketing person for Ogilvy and Mather and then Forbes, to come and head the marketing team at Facebook. And then my youngest daughter, Ariel, graduated Claremont McKenna in Southern California and got a job working for a company that did social media campaigns um, in Palo Alto. So we wound up with three or four kids, with one remaining on the East Coast that we stayed east for. But that birth of the first grandchild was the driving force.
Yeah. Yeah.
Um,
That'll do it.
yeah, I still remember my wife holding the newborn infant and looking at me and saying, "I'm staying. Are you coming?" So it was about a 2-year transition to find an appropriate suitor to actually buy our home and dental practice
Mm-hmm.
and keep up, maintain things in a fashion that I would be happy with.
Mm-hmm.
And then fully migrated to California in 2013. And around that time, um, I had already been doing, even before my son was on everyone's radar, I'd been doing lecturing for Aura Pharma, the company that founded Arrestin, the first antibiotic, so to speak, for gum disease that dentists were placing into the gum crevice.
Mm-hmm.
And I was also beta testing software for companies doing digital radiographs and whatnot. So I was keeping busy with what I call non-wet finger dentist
Right,
stuff.
right, right.
Um, and so I think it was around 2010 when Howard Farran of Dentaltown,
Mm-hmm.
who's a name that every dentist knows,
Right, right.
reached out to me and said, "Hey, Ed, I just realized that Mark's dad is a dentist. Maybe
Mm.
you can help me. I have a problem with my Facebook page."
Mm. That's
So I
fun.
helped Howard, and Howard convinced me to write an article for Dentaltown. I think it was in September 2010, called "Does My Office Need a Facebook Page?" And it was pretty well received. Followed it up with another article on technology in the dental office a few years later, and my career in adopting new technologies and whatnot. And then I started getting offers to speak at dental meetings, study clubs, conventions, and also calls from companies with ideas for new dental products, a newfangled smart toothbrush, a breath analyzer,
Yeah,
AI interpretation of digital radiographs, robotics to replace the dentist,
yeah,
anything you typically with a technology base
right,
is what they
right.
sought advice for me from how to get their products ready for market. Um, and the one frustrating area was when they reached a point where they needed funding.
Mm.
Because fundraising is something that I had never done.
Right.
My youngest daughter, Ariel, is in venture capital and at the time was working for Kleiner Perkins, which is one of the larger venture capital funds in the Silicon Valley. And while they didn't do dental investing per se, she introduced me to colleagues in the business who did. And we were able to, kind of um, bring dental investing, into the forefront and get on people's radars that investing in dental technology is a place that might have a future.
Mm-hmm.
Excuse me. Um, so from that period, from like 2012 to around the time of the pandemic in 2020, I was pretty busy. Even though I wasn't doing much dentistry,
Right, right.
I did connect with a local office here
Mm-hmm.
that let me use their facility when I wanted to treat patients, and I still treated some family members and did some second opinions and helped cover for the owner dentist when they went on vacation, things like that.
Mm-hmm.
But for the most part, keeping my fingers dry.
Yes.
And when the pandemic hit, it was, I think I had over 20 lectures scheduled in 2020. And I said to my wife, "Hey, this might be the end for me. I'm 66 years old and, I've practiced actively and owned my own office for 35 years. I've spent the last 7 or 8 years giving back to my colleagues and
Right.
teaching them how to build a Facebook page, how to use Facebook to, advance their marketing and build their presence online, and how to learn how to evaluate technologies and screen the practical stuff that made sense for them from the stuff that would probably wind up in a closet gathering dust
Right, right,
and
right.
avoid those purchases.
Yeah.
Um, and I just don't see it as, groundbreaking or earth shattering or changing anyone's life or anything like that. And, I've had a long career. Maybe, the pandemic looked like it was going to be going on for a
Right,
while,
right, right.
And so, um, literally a month after that happened, and I made those comments to her, I got a call from Jeremy Krell, who was previously the chief dental officer at Quip, a smart, toothbrush company that
Mm-hmm.
was trying to bring a an economical alternative to, an electric toothbrush to people's homes. And Jeremy and I had met on the lecture circuit at various dental meetings, Chicago Midwinter, Yankee Dental Congress, Greater New York, etc.
Mhm.
And we shared a lot in common because we both managed a portfolio of companies where we were advisors for.
Mhm. Mhm.
We both experienced the frustration of raising funds for these companies when they reached a point where we couldn't take them any further without.
Mhm. Mhm.
Um, but Jeremy, being half my age and having a long life ahead of him,
Right.
took the bull by the horns and started Revere Partners, the first independent venture capital company that invests only in early seed dental companies and oral health companies.
Mhm.
Um,
Mhm.
and he partnered with a friend of his who had a long career at Bridgewater, one of the world famous hedge fund company. So he was a financial guy. And Jeremy said, "Hey, it's pandemic. We've already got a backlog of 50 plus companies that are pitching to us that need funding. How would you like to join us as a venture partner? And you'll meet people virtually on the phone. You'll do diligence. You'll share your thoughts on their ideas for, you know, bringing them, to fruition in the dental industry." And so I took it on.
Mhm.
And about a month later, I was asked to look at a company that was out of my normal comfort zone, which was mostly, high-end technology stuff.
Right. Right.
And I was asked to look at a company that was really a biopharma company. Um, and these guys were working with a monoclonal antibody, which, monoclonal antibody has been around forever, but for a lot of people, the first time they ever heard the expression monoclonal antibody was when the vaccine for COVID came out,
Right.
which was, of course, a monoclonal antibody.
Right.
Um, and these guys had a monoclonal antibody to eradicate P. gingivalis. Now, I had obviously heard of the P. gingivalis in my microbiology education in
Right.
dental school some 45 years ago.
Right.
But my knowledge was probably where 99.9% of other dentists was. Hey, that's one of the bad bugs that causes periodontal disease.
Right.
Period. End of story. And most dentists' knowledge of how the disease in the mouth is connected to the rest of the
Yes.
body
Yes.
was centered around a little bit of education we got that essentially said that when you've got gum disease and you've got inflamed bleeding gums, the local blood vessels also dilate, and the bacteria from gum disease can travel from the local blood vessels into the bloodstream to other parts of the body and
Right.
make you sick.
Right.
But we really didn't have a grasp
Right.
for specifically how that might have caused diabetes or heart disease or arthritis or
Right.
digestive cancers or dementia or any of these things that we now know there's a 100% correlative link
Right.
between the bacteria in the mouth and these diseases. And about 15 years ago, two famous periodontists, George Haji Shingalis and Rich Darveau, actually brought forth into the profession the keystone pathogen hypothesis, which clearly demonstrated that P. gingivalis is the ringleader, the big boss.
Mhm.
And the team at Keystone Bio, which was the company that I met back in 2021 and subsequently became a chief dental officer for them,
Mhm.
um, they were showing the whole pathway, how this bacteria was very happy living and causing gum disease in the mouth. But this bacteria spewed these vesicles off the body of the bacteria that contain toxic proteins.
Mhm.
And it was those vesicles, not the bacteria themselves, that traveled throughout the bloodstream, throughout the body, even crossing the blood-brain barrier to get into the brain.
Mm-hmm.
The blood-brain barrier is a marvelous evolutionary feature that has allowed humans to live as long as we live. It basically keeps our brain and the contents of our spinal cord and nervous system sterile
Mm-hmm.
by preventing bacteria from passing that barrier.
Mm-hmm.
Um, but the toxic proteins of P. gingivalis do pass that barrier.
Mm-hmm.
They do enter the brain. They do interfere with neuronal transmission. The body walls them off and tries to expel them. And the byproduct of that immune reaction is beta amyloid plaque formation, which we know is a hallmark of
Right,
Alzheimer's
right,
disease.
right, right.
And autopsies of the brains of Alzheimer's patients, in virtually 100% of those autopsies, reveal the DNA of the toxic proteins of P. gingivalis,
Mm,
not the bacteria, but the DNA from those toxic proteins.
right.
So we know and now fully understand the pathway. In addition, we also know that, I mean, they don't just go to the brain. These toxic proteins go into the liver where they actually inhibit glycogen synthesis, the very breakdown of sugar molecules into energy that gives our cells the ability to do what they need to do for us to function. Um, when glycogen synthesis is impaired, the individual is going to suffer from a form of diabetes because they can't break down blood sugars.
Yes.
And so, no matter how much insulin is given to them, um, their blood sugars are going to remain high. And amazingly enough, when you take a patient who is being treated for diabetes and the physician's having fits, titrating the proper dose of insulin, it doesn't seem to be working. Put that patient who has periodontal disease now through comprehensive periodontal care, and all of a sudden these physicians can manage a lot of these patients sometimes with diet alone.
So
Uh,
that makes me think what I had mentioned just a little bit ago, as far as the role of dentists as primary healthcare specialists. I think that's a good segue, right? Because look at the journey that you've been on and all that you've learned through all the technology, but through just being alert and aware and connecting with other people in the science of all of the oral systemic health elements. It begs the question as to why not more dentists seeing themselves and participating as specialists, within primary healthcare. I mean, everything that you're just saying should be part of an ongoing dialogue, an understanding the oral specialty with the rest of the healthcare system that just is stayed siloed, right? It just has not really happened to any great degree, at least from my perspective. Is that how you see it as well?
oh, absolutely. I mean, I've been there at continuing education lectures where what the lecturer said made perfect sense.
Right.
And I knew I was not going to implement that in
Yeah.
my office,
Yes.
for one reason or another. Or maybe I left, hey, this makes sense. Let me move forward on this. But
Right.
somehow the process never took hold. Maybe because I didn't see how it flowed into my care delivery and my
Right.
practice.
Right. Yep.
Maybe I was just too damn busy churning restorations
Right.
and
Yeah.
scalings and whatnot to even think about the global picture.
Yeah. It's a
And
model.
I had to make a living and treat patients. It's a really stressful career
Yeah. Yeah.
to have running an office that really requires, immersion into patients and running a tight ship with a tight schedule and patients on short appointments and whatnot.
Yeah.
Um, I think, one of the things that's really moved me a lot is oral cancer.
Hmm.
So I'm a big, I've been I in my residency at the VA hospital in Brooklyn in 1978, I was on the team that helped develop the protocol for oral cancer examinations for the entire federal dental service. And I was one of the only dentists back in the 80s, before I picked up a sharp instrument in the mirror to look at teeth,
Hmm.
I'm feeling the patient's neck and floor of the mouth and the cheek, looking for,
Right.
abnormal lesions in the mouth.
Right.
If I don't do it, no one else is going to
Right.
do it.
Right.
My
Right.
wife's a physician and admits the extent that the physician looks in the patient's mouth is to have them stick their tongue out so they can put a tongue depressor on and say, ah.
Yeah.
They
Take
start with the
that.
throat. They start with the throat and go right past the mouth.
Yeah.
So if a patient has an early lesion that's an a developing oral cancer or one that is capable of malignant transformation,
Right.
I'm the only one who's going to find it.
Hmm.
And yet, dentists couldn't get reimbursed for this service. It was part of their examination. And so when companies like Velscope came out with a terrific light, almost 20 years ago, that enhanced our ability to find lesions that our naked eyes couldn't see, um, the adoption has been very, very low. Only 10,000 units actively used worldwide,
Mm.
with over 1 million dentists worldwide.
Yeah.
Because while we want to do good for people, we also need to do well for ourselves.
Right. Right.
And part of the web that we need to spin in promoting ourselves as primary healthcare practitioners is in developing, so to speak, a new image, one where we get envisioned not as a walled off profession from medicine,
Hmm.
which dentistry currently is,
Hmm.
but a subspecialty of medicine,
Yeah.
the oral health specialist. And I'm envisioning a time where patient presents for triage of symptoms. And the symptoms may be shortness of breath or palpitations or dizziness from low blood sugar or maybe early dementia or maybe arthritic pain or a number of variety of medical maladies that they seek a physician for.
Hmm.
And the physician is going to say to them, before we take a deeper look, we need to get you cleared by our oral health specialist.
Hmm.
Because many of the diseases that you may potentially be developing or suffering from that are causing these symptoms
Right.
have their root in poor oral health.
Yes.
Um, so, one of the companies that I work with, and also as chief dental officer for, is a company called VIOME.
Hmm.
VIOME. Now, VIOME has been around for about 8 years, and for the longest time, they were a gut health company solely. Um, and ironically, not long after I started working with Keystone Bio and really started, channeling myself into learning everything I could about P. gingivalis,
Hmm.
I was listening on the radio, as we do on a weekly basis, to my oldest daughter Randy's Sirius XM business show, and she had a guy on that she was talking to, and he was talking about P. gingivalis.
Mm.
Now, Randy is not a scientist,
Right. Right.
and I'm like texting her during the show, Randy, what's going on here? Where'd you find this guy?
Yeah.
And you need to connect me to him.
Yeah.
It turned out to be Naveen Jain, the
Okay.
CEO and founder of Viome.
Hmm.
And turned out we had a lot in common. My youngest daughter, Ariel, had actually worked for one of his son's startups
Mm.
prior to her current job in venture capital. And Naveen said, Ed, I want you as an advisor because we're developing an oral health product and
Hmm.
I need your advice on where to go with this.
Hmm.
And then 2 years ago, I became their chief dental officer when they were ready to bring the product to market. And while there are a number of companies that are out there that offer salivary diagnostics, simple screening where the
Right.
patient spits in a tube
Right.
and the sample is now analyzed,
Right.
very non-invasive, no cutting, no scraping, nothing.
Right. Right.
VIOME is the only one that from that simple salivary screen can actually screen for squamous cell carcinoma of the mouth and throat with a 95% degree of sensitivity.
Mm. Um,
So that's incredible. If you think about an oral biopsy
mhm.
of a suspicious lesion, only has about a 65% degree of reliability. So here we're looking at something totally non-invasive
Yes.
that we don't have to wait for a red spot, a white spot, or something like that. We
Right.
can screen before there's any sign and find lesions earlier, which we know is the key
Right.
to minimizing the extent of treatment and the life prognosis for these people. But Viome salivary test doesn't stop there. It also does a deep dive into bacterial activity and the oral microbiome. So they can do things like analyze the threat of P. gingivalis to not only that individual's gum periodontal health, but
Mhm.
to their systemic health.
Mhm.
And they can produce, based on the salivary test that they do, they can produce custom probiotics and prebiotics and
Mhm.
postbiotics for that individual, tailored to their salivary microbiome,
Right.
that in the form of a lozenge and a toothpaste that can be taken on a daily basis that can promote the growth of healthy bacteria and suppress the existence of the pathogenic bacteria. So that's really exciting stuff. But
Mhm.
again, like you said, how do we get dentists to implement this test? And one part of me says, hey, it's our duty,
Right. Yeah.
our role as dentists to screen for oral
Right.
cancer.
Yeah.
And if there's a screening test, we should be mandated to
Right.
run this test.
Right.
But then, of course, who's going to pay for the test? Dental insurance is not going to pay for the test because they're only interested in making themselves money. And if there's cost savings to be procured from diagnosing and treating oral cancer early,
Right.
that benefit is going to be realized by the medical insurance carrier, who's going to be footing the bill for over $1 million anytime a patient has a negative, outcome with oral cancer.
Right.
Um, but the way these companies that are business-like look at it is they don't look at the lives they're going to save. They look at, well, we're going to be paying for a lot of tests on people who test negative, who don't have oral cancer,
Right. Plus, I
right?
think there's a
And
lot of
they look
hope.
at that as a waste. They look at that as a waste of money because it didn't save them any money because those people were never getting sick.
Right. Plus, I think the fact that the insurance companies are wagering that they also will not ultimately be responsible for those particular people if they change insurance companies and that sort of thing. So the time bomb may not go off on them anyway. So I
Yeah.
think to in this whole conversation, I mean, there's so many factors I think that need to shift to some degree, right? Because the cost and who's paying the cost is really small cost overall to be able to determine and get accurate data around life-changing, life-affirming measures that people can take that are oftentimes simple strategies to be able to make improvements. But it's an insurance. It's historically been like healthcare overall for the longest time. It's based upon cheapest access to something, right? And it's not necessarily health because it's not a healthcare system, which I think is another part of the problem, right? It's not really, it's a disease care system. And even then, it's cost containment relative to who's going to be doing the diagnosing and the delivery anyway, right? So this is very convoluted in terms of what the answers need to be. But somebody, as I talk to different people about Viome specifically and about a lot of the technologies that are available with clients I'm coaching is is a lack of seeming motivation to go more broadly, to get out of the narrower worldview, maybe because the business model seems like they know that business model, they're busy, like you say, but unless more of that keeps getting pushed out, this becomes a harder journey.
Absolutely. I'm pleased to be working with earth movers like, the executive, of the ADA, Will Ginobili, the dean of Harvard Medical School, people who see the things that I see,
Yes,
and we all want the same thing. And, we have broad goals
yes,
uh, to really move dentistry, into the role of primary care,
yeah,
uh, you know, subspecialty, so to speak,
yeah.
of medicine.
Yeah, that's great. So what do you see like looking ahead now with given some of the things that you've shared and the challenges out ahead, the interesting opportunities? I mean, amazing technology, amazing science development. The knowledge is there. The tools are increasingly there. What do you see out ahead over the next 10 years? What would you like to see, and what do you imagine if there's any difference between those?
Well, I'm going to be working a lot in the next couple of years with insurance executives
Okay,
across the country,
okay.
um, showing them the benefits, of covering these kind of diagnostic screenings
Hmm.
to them in the long run. Um, Change is hard, as you know,
Yeah, yeah.
and I think one of the biggest obstacles we have to this effect is dental insurance.
Yes.
You know, if I could have, you know, I'm a little strange. If I found a genie lamp on the street,
Mm.
and the genie popped out and said, "What's your wish?"
Yeah.
It would be abolish dental insurance and
Yes.
have dentistry covered under medical insurance.
Mm. Okay.
If we could accomplish that, then dentistry would be essentially a medical discipline,
Yeah.
which it really should be. Um,
Yes.
that's a big obstacle and a big hurdle that won't happen overnight,
Right. Right.
but can happen gradually with
Right.
change
Right.
as more medical carriers start seeing the value of embracing reimbursement for more and more dental procedures.
Hmm.
So
Yeah.
that's one of the steps that I'm going to be working on in the short run
Great.
to bring my long-term goal of seeing dentistry move into the discipline of medicine as a specialty.
And then hopefully that will increase communication as it doesn't appear so siloed between experts across those elements. Because like you just mentioned, as far as dementia and the effect of just like systemic inflammation and where that's coming from an oral gut microbiome and all of that. I mean, it's like there's got to be more interdisciplinary conversation from my perspective.
Absolutely, and I laud the efforts of PDS Health, formerly Pacific Dental Services, the largest union of dental offices on the West Coast, for their adoption in their 1,000+ offices of the Epic electronic health record system, so
Mm.
that dentists have access to patients' medical records
Hmm.
and physicians have access to patients' dental records.
Yes.
And so fostering more communication between medical and dental professionals.
Yeah. That's good. I've often thought about the role of hygienists, and I know we have a world of kind of increasing uh, demand or request, however you want to say it, for pay for hygienists. And I know that for many practices across the country, that's a challenge, especially since
Uh,
the pandemic. But to see them as
uh,
more than just to be seen as more than just cleaners of teeth, but to
oh,
be
absolutely.
voice for, and I know there's many hygienists who've moved in that direction, or moved as a one of the key pieces for connecting the dental office to the rest of the healthcare world to stand in the gap a bit, where the dentists maybe don't always have all the time themselves to be able to navigate all this.
Well, when I use the term dental professional, I'm referring to both dentists and hygienists.
Yes. Yeah.
Hygienists are essential caregivers in the practice. In many practices where the patient, mouths have been properly restored, and they're basically visiting the office for periodic maintenance and prophylaxis, and um, 90+% of their contact is with the hygienist.
Yes.
That's their go-to dental professional
Right. Yes.
is the hygienist.
Yes.
And so at VIOME, we understand that, and we're partnering with and working with and recruiting hygienists to be on board because, the hygienists are they're more motivated to really sit with their patients
Yes.
and explain, the correlation between oral health and systemic health.
Yes.
Whereas dentists are in there, I got to produce, I got to cut
Right.
this crown prep, I got to do
Right.
this filling.
Right.
Yeah, hygiene exam in operatory 3, in and out in a few minutes, that kind of thing.
Yes.
Can't really sit and chat with this patient
Right.
about how the oral systemic connection
Right.
goes.
Right. Yep. I agree. Well, this has been fascinating. I mean, I love going back to where we started. I love the arc of your career, and I'm glad that even though there was a sense of temptation, and maybe this is the end during the pandemic for you, I think the reinvention, the next phase of reinvention, the contributions that you're making now, I think that's wonderful. I think the whole the commitment to engage the insurance world. I mean, that is, yes, I think probably going to be an uphill challenge, but somebody's got to start doing it. So why not?
Matt, I realize also a certain sense of responsibility. I don't know if
Yes.
that makes sense.
Yeah, no, it
But,
does.
but my name does open some doors
Sure.
that others can't get a door
Yeah,
open to.
yeah,
And,
yeah,
I thank my son for that,
yeah.
for, putting the Zuckerberg name on the map, but it does enable me to get access to and phone calls with
Sure. Yeah,
and get things done that others that may be more talented and more knowledgeable than me can't.
yeah. I like that. I
So
appreciate that.
I feel sort of a sense of responsibility to
Yeah,
be this, I'm the ombudsman for the dental profession, so to
yeah,
speak.
yeah. Well, it's been a great conversation. I feel like we need to get together for a part two down the road here just a little bit because I feel like there's so much more that we could talk about. But this was a great both overview and I think you shared a lot of specifics as well. So for for listeners who are saying, I would like to know more. I would like to get involved in some way with some of what we're talking about. If they'd like to connect with you in some way to say, what can I do? What would you suggest? What is a possible next step or two that you would recommend?
Well, they can reach out to me on LinkedIn. They can reach out to me on Facebook at Painless Social Media. They can email me at ezuckerberg@gmail.com. And I'm actually redoing my website right now. My website is painlessdrz.com. And I want to have the repository of all the literature on oral systemic disease that I can find. So we're building a giant index for people to really go there and visit painlessdrz.com and have access to a total knowledge base about P. gingivalis, fusiform nucleatum, all the pathways of how these bacteria create diseases, and kind of be, a source for knowledge.
Yeah, I think that's a wonderful contribution as well, because I do think there's more and more people who know that there's a lot of things that are true like this, but either do not make the time or not sure quite where to look to gather the best information. So I think that's a wonderful contribution. So I'm hopeful that people will reach out and connect with you. I'm imagining people will be as fascinated as I have been to kind of to hear your story, your journey today, and what you're involved in. So thank you. Appreciate your time.
Pleasure, Matt. Take care.
Yeah, thank you. So, this is the Truth Behind Dentistry podcast. We've been with Dr. Ed Zuckerberg. I hope you found it compelling, and I hope that you'll reach out to him. And I hope that you'll be excited to explore more of the oral systemic connection and just some of the different opportunities that are available for diagnosis and maybe rethink what you might want to contribute through your practice. So hopefully you have subscribed. If not, please do invite friends, and we look forward to seeing you on the next episode. Thank you.